So, hello again. I will try to be quite short to be able to discuss about this question. First, my disclosure. You have noticed that I am a French European male, quite old, and as you know, when you discuss research, you have always to think about who is doing the research, conflict of interest, of course, but also culture, because our research are always related to our culture, and this is not so often recognized, acknowledged, and we should do better about that. As Bertrand told you, I am professor in biostatistics and not in child and adolescent psychiatry. That's life. So it may be a conflict of interest because you can imagine that I like numbers, which is not so obvious in fact. I practice child and adolescent psychiatry, outpatient practice mainly in a university hospital, which means that my patients are not the same as you know as the day-to-day patient of my colleague in private practice. I work in my hospital is in a disadvantaged suburb of Paris, and so I see patients from all socio-economical status. I like to read paper in neuroscience a lot, but to be honest, for my clinical practice, I use more psychoanalytic construct. This is my way to do my clinic, and so there is some kind of tension between the neuroscience that I like to read and clinical practice that I have to do. And I think I am not alone with that. And I have noticed that there are many young colleagues that are in this congress. You have put an emphasis about that, and this is very good. And perhaps they feel the same situation. And of course, when we are planning to do research, we have to think about that. So, first point about research. We have to take a step back and just to ask, in fact, what is a good research? And the main answer should be a good research is a research that is good for patients. Okay, but just read international scientific papers, journals. Read the studies. Do you really believe that all these studies are toward directly the improvement of psychiatric care? Most often this is not so obvious. And so, in fact, people are doing research not only for the good of patients. Sometimes it is also, and this is important to notice it, we do research because it helps us to understand our patient. Of course, this can be good for patients, but it is good for us too. You know that when you practice child and adolescent psychiatry, many times you don't really understand what happens, because it is much more complex than some in nephrology, for instance, where you have a kidney, you can focus your attention on an organ. We are not in the same situation, and many times there is a mess about what happened, and we are destabilized by that. And if you are regularly destabilized by that, this is uncomfortable, and sometimes we feel to do research, to be obliged to do research, to put sense, to understand what happens in our clinic. To deal with patients, we consider most often that we have to improve the situation of my patient in front of me. But you know, and I am sure that in Northern Europe this is the same, there is a lack of child and adolescent psychiatrists. There is a lack of psychologists. In some countries, psychological treatment are not reimbursed. And so we have also to think to the patient we are not seeing in consultation. There are in many countries are patients in the street, at home, in school. They need care and then do not have care. And so we have also to think about the healthcare system. And main progress are likely to come from the improvement of the healthcare system. Of course, sometimes we do research because we speak in Congress. We look smart. We look intelligent. And all research do not seem to be as smart as other research. I guess that if you are doing research in very basic science, in very basic cognitive neuroscience or genetic or imaging, perhaps you have the feeling that you look smarter than people who are doing research in epidemiology or even in social and human science, which is soft science as compared to hard science. And of course, many of us do research because this is the only way to become a professor. And to become a professor, you have to look smart too. And so you are likely to do research, smart research. Interestingly, my feeling is that many people who are doing research in child and adolescent psychiatry, and in particular in adult psychiatry, they do research because this is a way to understand who they are. And in the past, it was the case with the psychoanalysis. You know, many child and adolescent psychiatrists were in a psychoanalytic treatment to understand who they were. And in fact, it is important for clinical practice to understand who you are. And I think today, many people are doing research in cognitive neuroscience, in genetic, etc. And when you dig, you see that, in fact, their design, their object of study, many times is related to their own problems. But this is the secret. We should have a discussion about that because, you know, when you are personally implied in your research, perhaps you are biased in the way you describe them. And there is a taboo about that. You can do research because this is elegant. And here again, this is not enough acknowledged. You know, research, science can be beautiful, like a beautiful picture. And many people do research because it's great, it's elegant, as if you were writing a good novel, writing a good music. You are doing good science because you create something which is great. And simply, many people do research because it makes them happy, you know. When you are dealing with patients every day, you have to take a break, and doing research, you are breathing about something different, and it makes you happy, and this is good. It can be considered as some kind of therapy in a way. Okay, so first point, when you engage yourself in research, you have to ask all these questions because according to the answer to this question, you will select a different way to do research. Second point, when you do research, you know, you are working on patients most often because you are doing clinical or research in medicine, in child and adolescent psychiatry, which is a part of medicine. And so implicitly, you conceptualize your patient in a way, and it is on the basis of this conceptualization that you are going to do some research. It seems to be quite obvious. If you consider cardiologists, for instance, how do they conceptualize their patient? Mainly a body with a heart and vessels. And all their research, in fact, is based on heart and vessels. And it seems to be obvious. Okay, but what is one of the most important problems in cardiology at the moment? You know, many diseases in cardiology are chronic disease. And what is a big problem in chronic disease? People do not take their medication. Observance. Do you think that if you study only heart and vessels, you will understand why your patient do not take anymore their medication? So in fact, even in cardiology, this is not simple. So in child and adolescent psychiatry, how do we conceptualize our patient? This is not the same as in cardiology. Well, you could say we conceptualize our patient as a brain, you know. Science behind psychiatry is neuroscience, and neuroscience, you are interested in the brain by definition. And in child and adolescent psychiatry, we are interested in a developing brain. And you know that nowadays ADHD, ASD are neurodevelopmental disorder. And so, in fact, we conceptualize sometimes our patients as a developing brain, and this is why we do neuroscience. It makes sense. Okay, but when you have your practice, do you consider that your patient is only a brain? I don't think so. There is something else. When you use evidence-based medicine, if you have in front of you an adolescent with a major depressive episode, you will think to what is the treatment. Will I prescribe an antidepressant drug? Will I prescribe mindfulness, CBT, psychodynamic treatment? You will rely on evidence-based medicine, on randomized control trial. And in a randomized control trial, in evidence-based medicine, you do not consider a brain anymore. You consider statistics and an average patient. And so, you are engaged in a relation with a patient. Suddenly, if you think to the treatment in evidence-based medicine way, then you will consider that, in fact, your patient corresponds to an average patient that are in studies, in papers, where there are statistics. And so this is the reason why sometimes we say, what is your patient? Well, this is a depressed patient. This is an ASD. We conceptualize them as some kind of average patient. And so this is important to know that when we are doing statistics, we are dealing with average patient. And in fact, in front of you, you have not an average patient. You have a person you meet. And this is a unique person. And so, in fact, your treatment has to be adapted to this particular person. And so you have to be, perhaps you are interested in research, you could be interested in research about the real person that you are meeting. And what is particular in our profession is that we most often do not meet a person, we meet a family. And this is quite difficult to do research, to do scientific research with families. Because this is extraordinarily complex, you know. They have their own brain, interaction, and there is a society, the culture behind the family. But, in fact, in practice, this is with what we are dealing. We are dealing with families, and perhaps we should focus research on families, which I have seen that you will have talked today with research on families. This is very important. Not enough research about families in child and adolescent psychiatry. So, to sum up about that, to be true, at the moment, we have mainly research about brain and statistics. Very few research about the child I have in front of me. Who is this adolescent in his life, in his spirituality? Very few research about that, and as I said, very few research about family. And this is proper to medicine in general, in fact, not to child and adolescent psychiatry. Perhaps you know this very good book, The Progress of Experiments. This is the study of the history of the methodology of biomedical research during the 20th century by Harry Marks. And this author showed that since the 19th century, there has been a tension between biology and statistics. And at first, you know, in the 19th century, biology was the winner because of germs, of antibiotics, you know. Germs and infectious disease with bacteria were a real public health issue in the past. And with the discovery that tuberculosis, etc., were due to germs, it has been a huge revolution, and vaccination, of course, a huge revolution in medicine. And so biology is very strong because of that in medicine and in child and adolescent psychiatry. But after the Second World War, statistics have been more and more important, and you know that nowadays we evaluate treatment not so much with biology, but mainly with statistics, and this is called evidence-based medicine. So, we can say that at the moment, and for the 20, 30 years that were before, we were in the good old time of child and adolescent psychiatric research. The paradigm is that there is some kind of galactic between biology and statistics. You know, biology, that is brain imaging, genetics, cognitive neuroscience, etc., fundamental research in general. This is good to find new way to treat patient. And after, you have to apply that to real practice, and so you have to do clinical research, including randomized controlled trial, of course, which are the cornerstone of evaluation of treatment. And there is also epidemiology, because in fact biology, it is not easy to find risk factor with only biology. You need to do also some very simple things. Family history of depression, is it a risk factor of depression? This is important to know that. And biology alone is not enough. And so you have some kind of relationship between people who are doing research in biology, people who are doing research in statistics. Sometimes one has more power than the other. In the past, biology was more in fashion, statistics less. My feeling is that at the moment, if you are looking high impact factor journal, statistics are more and more in fashion, and biology, fundamental research, a little bit less. This is a feeling only. But here you have, and you have students that will decide to do research in genetics, and others that will do research in epidemiology, and that's life. Of course, there is always a question, where are social and human science? Why so few papers on history of child and adolescent psychiatry, on anthropology? Religion, for instance, is a protective factor of addiction and suicide attempt. And religion, is it related to statistics only and to biology? No, we should do research in anthropology, sociology. I am sure that, you know, today the way we consider autistic patient or hyperactive patient, this is related to how our society deal with difference, and you know that this is a very sensitive subject. And so few papers in our famous journal about this area. Okay. Anyway, this is what we are, and that's life. Our research is like that. We could say, this is quite great, because we advance, we are doing research, this is fine. Even if this is true, it becomes more and more difficult in most countries. Ethics requirements become more and more difficult, and you have to do a lot of paperwork, and often people in ethics committees, they do not understand what you propose, and say, no, you are doing psychiatry with kids, and this research is very scary, and we don't want that, while in fact they don't understand what we do. And the privacy, you know, we have to be very cautious about data, and this is, of course, this is normal. Ethics and privacy are very important. No problem with that, but it makes research more and more difficult. I'm sure you know that. And the other point is a good point, is that you have noticed that nowadays there is a massive appeal for research. More and more clinicians want to do research, and this is a very good news. This is very good. But there is a side effect. The side effect is that if more and more people are doing research, there is a huge competition. And so it is difficult to publish papers. And because it is difficult, and because you need that to become a smart physician, sometimes there is a temptation to do some kind of fake science. You know, this is called spinning, to put some pink painting on your paper just to make them smarter. This is a big problem of science today. And another point is perhaps some kind of saturation. Have you the feeling that there are real breakthrough nowadays in child and adolescent psychiatric research? There are good papers regularly. That's fine. Okay, that's real. But real breakthrough, I have not this feeling, and I am not alone. Some people say, well, you are doing all this research. Okay, that's fine, but is it really useful for the patient in the day-to-day life? And recently I have been very surprised by a paper written by Ioannidis. I don't know if you know John Ioannidis. This is one of the Pope of evidence-based medicine today. He is professor in Stanford. He has written a paper that has been downloaded more than 2 million of times. And he is quite provocative, but this is quite good to be provocative in science. And so he wrote this comment to a paper, and the title of the paper is quite provocative: Therapy and Prevention for Mental Health. This is our job. What if mental disease are mostly not brain disorder? Good question, but the summary goes more in detail and quite interrogative. Neurobiology-based intervention for mental disease and search for useful biomarker of treatment response have largely failed. I don't know. I don't say this is true. I just say this guy, who is a very famous people in evidence-based medicine, say that what we did, that is coming from neurobiology and translated to clinical reality with statistics, this has failed. Clinical trials should assess intervention related to environmental and social stressor with long-term follow-up. Social rather than biological endpoint, personalized outcome, and suitable cluster, adaptive, and N-of-1 design. We will come back to that. This is quite technical. Labor, education, financial, and other social and political decisions should be evaluated for their impact on mental disease. So you will say, well, who is he to say something like that? He's not a psychiatrist. He's not allowed to say that. Okay, perhaps. But perhaps we have to listen to people who are outside our area, because perhaps they see better the situation than us. Okay, so take a look. Is really 2020 a time for a big turn? So is Ioannidis right? And how could we think a different research? My feeling is that perhaps he is true, perhaps he is right, perhaps he is wrong. Tomorrow I know that Johannes is going to have a lecture about a new treatment in anorexia nervosa. Perhaps he will speak about the amazing things that he is going to do now with leptin, treatment by leptin of patients with anorexia nervosa. This is based on neuroscientific, neurobiological studies, and perhaps this will be a major revolution in the treatment of this disease that is very difficult to tackle in our clinic. So perhaps neuroscience can be useful to deal with patients. But if you take a step back too, what has been the treatment in psychiatry the most advertised in the last 10 years? Mindfulness-based treatment. Third generation of CBTs. And you know that mindfulness does not come from neuroscience. It comes from Buddhism, from religion. So indeed, perhaps Ioannidis is right. Perhaps we should deal more on sociology, anthropology, psychology of the person than on neuroscience. And because we are now in a society that is changing a lot. For instance, there are new concepts and domains in medicine now. Patients in our organization in 20 years ago didn't exist really. Now, in child and adolescent psychiatry, they are so important. Association of patients with ASD now propose to us that autism is only a difference. We have not to treat ASD. We have to treat the distress that is related to ASD, because ASD is like being less-handed. I don't say this is true. I say this is what patient organizations say. And we have to take that into consideration. And we have to take that in consideration in our research too. And we do not do that at the moment. In cancer, you have personalized medicine, as you know. But what we do every day is personalized medicine. So how to think personalized medicine in child and adolescent psychiatry? Digital health. There are many thousands tools on smartphones that deal with anxiety, and our adolescents and children use their smartphone every day. Perhaps we have here something extraordinary to propose sustainable treatment that can be proposed to many, many patients. We have big data, we have health insurance database, we have also, for instance, Facebook, the posts on Facebook that are done by adolescents. There is here a huge amount of data. This is free, and this is quite easy to analyze. We are going to come back to that. Open data. Nowadays, many data are open, and so it makes things much easier. It costs less to analyze data that already exist than data that you have to look for. Health economy. You know, in all countries, health insurance do not spend enough money in child and adolescent psychiatry as regard the necessity in terms of disability adjusted life year. This is just reality. And there are papers about that. If we use health economy, we will show that our treatments are more cost effective than in cancer, and they will be more reimbursed. And so we have to do research in health economy, and there are too few papers about that now in the literature. The notion of global mental health, that is to include psychiatry in mental health and society and culture. Implementation research, that is to do research that is not only evidence-based, but that can be sustainable in the country where you live. If you live in a poor country, you will not be able to use the most efficient CBT because it costs too much. And so we have to adapt treatment to the reality of the situation. Meta science, fake science. You know that in psychology, in brain imaging, many papers have been considered as fake, and so we have to be careful about that. So new concepts, new domains, and fortunately, new methods and tools that make things easier to be innovative. To evaluate treatment, we use randomized controlled trial. Okay, no problem. Nowadays, you have alternative to randomization. You can use observational study, you can use health insurance database to evaluate treatment, and data already exists. And I know that in Northern Europe, where you live, you are very strong in having very big database with a high quality of data. You are just champion about that. Bayesian design, this is a new way to do statistics. For instance, with this type of design, we can use information that are available in adult psychiatry to do inference about child and adolescent psychiatry. Statistics are changing a lot. You have now data science, machine learning. I don't know if it will be a major progress in medicine, but why not? And a part of data science, a specific area of data science interesting for us, is automatic language processing. Because with automatic language processing, you are able to analyze big data in Facebook, and in forum, you know, where adolescents say, well, I take my Ritalin or my methylphenidate, how I am. And with automatic language processing, you are able to know the side effects and the efficacy of a treatment just when adolescents say that in forum without any input of physician. Psychometrics have changed also. Borsboom proposed now to forget factor analysis and to use network analysis to analyze scales. And very interesting for us, now there is a comeback to small is beautiful. You can do studies with a small sample size that can be relevant, very relevant on a clinical point of view. And of course, in child and adolescent psychiatry, this is very useful because we have to deal with infant, small children, young adolescents, old adolescents, and often sample sizes are small. Case studies, there is a comeback on case studies. N of one study, that is, you study 1, 2, 3, 4, 5 patients every day, and you can do statistics with that. And most important, qualitative research finally becomes acknowledged as they should be. And now you can publish in the European journal with qualitative research. And with qualitative research, you have access to the subjective life of patient. And what is, when you take methylphenidate and you have ADHD, what is the feeling that it is yours? And you know that many adolescents decide to stop to take the treatment when they are 15, 16, because they feel different. We need to do more research about that. This is my last slide. I would say, young colleague, just do it. Don't be afraid by resistance. We old guy, we are used to our good old time. We are used to do our research as we did during 20, 30 years, and change is a little bit difficult for us. You are young, you are flexible, you are ready to use new paradigm. So in practice, find the good team and find good collaboration to do research. You don't need necessarily a so large amount of money. This is not true. Small can be beautiful in child and adolescent psychiatric research. Do research that makes you happy. This is, if there is only one advice, this is this one. And be creative. Don't be shy. Be able to think different. And thank you for your attention.